my first question, because I'm a pulmonologist, so I in my work, in my job, I'm in charge of a lot of the lung cancer patients in a different stage. Yeah. Now today we focus on the perioperative the patients. That means we do a lot of job for those patients who have the chance to have the operation. So my question is, the first question is about the how to say the management of all these patients. So in your opinion, so it's the surgeon, maybe it's a surgeon, thoracic surgeon, or maybe it's our pulmonologist should be in charge more of such kind of patients. That's my first question. So who should be pay more attention in such kind of situation patient? Yeah.
I mean, so you're asking that whether to give the adjuvant treatment or not, so that kind of things?
What? Sorry?
So your question is who should be in charge of deciding the treatment strategy?
Yes.
So I think that may depend on the countries or institutions. Even in Japan, some hospitals, the surgeon is very strong. Some hospitals, the oncologist is very strong. So depending on the institutions, this may be different. Mm-hmm. And also, in the States, probably the medical oncologist is the biggest voice. But I think that what is most important is to discussing among the people with the different modalities, like medical oncologists, pulmonologists, surgeons, maybe pathologists. So those kind of the discussion may be the most important.
Okay, so you maybe recommend the MDT the style like in such kind of situation. So
yeah,
but yes, please.
Yeah, ideally the MDT, but it's not possible. I mean, all the people are very busy so it may be a bit difficult to share the same time with many stakeholders. But ideally, yes.
So, Professor, in China, and especially in Ruijin Hospital, I think like in such as a large hospital, that will be the same situation. The surgeons are very busy. So they have a lot of surgery to do. So, in my opinion, they might not have enough time to discuss every case with our pulmonologist. So they do the job of surgery, but we can be in charge of all the perioperative things, management like this. So that's why I have such questions. So maybe we can have a more precise the management, precise strategy for such kind of patients, because we can do the before we can do some preparation before the surgery, and then we can, after the surgeon finish the surgery, we can take over the patient to do the successive things after. So I just want to, do you agree with such kind of management or not?
Yes. So you are saying that to have some kind of the general strategy for each patient, like if the patient has stage 3 and the EGFR mutation problem, then giving the osimertinib for 3 years of routine. Also, such kind of the agreement should be made before the surgery for any patients, right? So that's what you mean, right? No?
So not for you, it's not a question, right?
Yeah. So I'm asking that your opinion is to have some kind of the general principle for the management of the patients. For example, if the patient is stage 3 disease with EGFR mutation, then osimertinib is a standard procedure.
Yes.
So such kind of making the rule is important. So I think that is very important.
So because you are very big surgeon, so maybe you are very busy too. I mean, So no, I just wondering how we manage such kind of things in Japan.
Yeah. So for example, giving the osimertinib after the patient with HL mutations almost standard of care. So we don't have to discuss much about that usually, right? So we tend to concentrate on the more difficult cases, like patients with older patients with some slight ILD or something like that. And then the selection of the treatment will be difficult, and we need to have the MDT discussion.
So in your department, you might prescribe some chemotherapy to the patient after surgery, right?
Yeah, so that depends on the hospital. So that before I moved to the current position in the Kindai University, usually the surgeons give the chemotherapy, also give the osimertinib.
Mm-hmm.
But now those patients, the drugs are given by the oncologist. So depending on the hospital, it's different.
So now in your current hospital, you can prescribe the target therapy to the patient.
We do not. Actually, most of my work is now administrative, so I don't see much patients. But for my surgical colleagues, they do not give the chemo.
Okay, so who you assign such patient to where? To your
medical oncology.
Oncology. So you not to pulmonology.
Yeah, so we have a lot of the pulmonologists here, but they are mostly concentrated on the diagnosis. So they diagnose biopsy, and then they send the patient to medical oncology or surgery. And then once the surgery is finished, then go to medical oncologist. So those are the in our hospital system.
Okay, thank you. My last question. If you have a patient's lung cancer patient harboring the EGF1, the TGF1 positive mutation, so after surgery, so what's your before the surgery? So what's your recommendations in such kind of patients? You recommend such patients to receive the target therapy first, like the neoadjuvant therapy, or just recommend patient to take surgery, and then after we give the patient the target therapy after. Yeah.
Because we don't know the effects of the neoadjuvant TKI before the surgery.
Oh, okay.
So
if we have biopsy before.
No. Effect of the neoadjuvant. We don't know the benefit of the neoadjuvant osimertinib.
Okay.
Not yet, right? So the standard procedure should be the initial surgery followed by the adjuvant chemotherapy, then adjuvant osimertinib. I don't think the neoadjuvant is a proven approach.
All right. Okay. So okay. I get it. I mean, okay, understand. I'm finished my question. Yeah. Thank you.